can still, we still need to do more critical work in getting that anterior tilt exactly right and reproducible in every patient. So if you have a study where you have an average cup position, that's not good enough. What you really need to know is how many are out of the range, above the angle. And again, just a study published in Total Hips this year, a very large study from a large center, showed 30%, even after intensive teaching, the cups were too steep. And now with x-ray techniques, in the last year, with 400 cases, we've had no cups above 50 on a standing x-ray. So with refinements and techniques, I think we can get there and get good cup positions. And I think that's the way we're going to eliminate these wear problems. But you know, we still need years of work to demonstrate that. So those are my thoughts on the adverse wear problems. And just to put this in perspective, we've heard a lot about adverse wear problems with metal bearings recently. Incidentally, I'm putting together my data on the 2,400 resurfacings that I've done, and so far we've had a 0.2% failure rate from wear problems. So it is a problem. It's not a very large problem in my hands. I will probably have more failures because it takes time for them to develop. Some of these patients don't have 4 or 5 year follow-up. But on the other hand, we're also learning that the cup position is critical, and we're getting better at that. So we should be reducing that problem. Other bearings also have wear problems. A few years ago, I'm not sure if it made it into the public press as much, but ceramic bearings got a really bad name. Ceramic on ceramic are another hard bearing alternative that's good for very active patients. And a lot of reports started coming out about loud squeaking of these implants, and there were reports of about a 1 to 5% revision rate because of loud squeaking. So, put that in perspective with the metal wear problems. My rate of failure so far is 0.2% over 10 years of doing this. The worst really would have been the Oxford group, where they've had about an 8% time-weighted failure rate at 8 years. And then, of course, all the failures with one particular brand implant, the DePuy, that had to be recalled, and they have about a 12 to 20% failure rate after 4 or 5 years. So,
weren't the Oxford group inexperienced surgeons?
I don't know the experience.
I thought they said they were assistants.
Yeah, they had multiple surgeons, and,
right.
And it wasn't disclosed how many surgeons were operating, if residents were operating, how well they were supervised. So that's a little unclear. They did use 2 implants, primarily the Birmingham and the Wright Medical, which have had very good results in the hands of other surgeons and have very low failure rates. So it's not clear why that particular group had such a high failure rate with implants that have been proven good in other hands. The DePuy ASR is a totally different phenomenon. That implant has had a very high failure rate in the hands of multiple very experienced surgeons, and there were clearly some design issues, and it had to be recalled. Then there's a third implant out there, the Zimmer Durham, which I'm not sure if it was recalled or just they stopped making it. It didn't have wear problems. It had a problem with the bone ingrowth in the socket, and it was taken off the market for that reason. It gets lumped in together with the wear problems from the DePuy and the wear problems seen in some centers, and the whole thing is a big jumble. So there were bone ingrowth problems with one cup, there were maldesign issues and wear with one cup, and then there are some accuracy of cup position problems that we all have to some extent, which is really the remaining problem that we need to solve. And there are a number of good implants out on the market, but even if you put those in a bad position, then you get a higher chance of wear. So I think that's where the challenge lies today. I was going into ceramics. Ceramic squeaking is a problem. Those require revisions. So which is worse, I'm not sure. And with plastics, there are also problems. A lot of surgeons are going back to plastics. The traditional plastics have a very high failure rate with plastic debris causing bone destruction called osteolysis, which incidentally I don't see in the metal wear failures. I don't see much bone destruction. I see tissue inflammation. With the plastic implants, we saw a lot of bone destruction, and I'm still revising plastic implants from years ago that have a lot of bone destruction, and those are very difficult to reconstruct. Cross-linked polyethylene, improved plastics, are supposed to be the solution to that, and we have data out to 8 years or so that looks quite promising. The problem is those are being modified quite a bit too. The smaller bearing plastics still have a problem with dislocation, and so the bearings are made bigger and the plastic is made thinner, and we have this cross-linked polyethylene, which has a lot of free radicals in it, and we don't know if after 4 or 5 years of these thinner plastics we're going to start having breakage problems with these. So The cross-link poly has been out for about 8 to 10 years and has pretty good results, but in the last 4 or 5 years, we've been making it thinner and thinner and putting bigger balls in there. So that may be a whole different story, and we still don't know, what the failure rate of those is going to be. So what I just wanted to point out to you is that we are learning many of the problems with the metal bearings, and I think we have some good leads on how to prevent the wear problems. We have wear problems with other implant systems also. This is not just the metal ones have the wear problem failures. And all of this, of course, is much more common in younger, more active patients. Those are the high-demanding patients that are high-demand activity patients who are really stressing these implants and making this whole field very challenging and very interesting. One final thing about the wear that I'd like to say is that some of the reports of wear have shown that they're disastrous problems and they're very difficult to revise, and that makes them unique, whereas a ceramic wear problem with squeaking is perhaps an easier thing to revise. I have not seen that. I've revised about 4 of my own wear problems, and I've revised about 5 or 6 from elsewhere around the country. They typically have metal debris. You can remove it fairly easily, in my experience. All the structures are retained. The revision is fairly straightforward. They have taken me on average maybe 10–20% longer than a primary hip surgery. I've never transfused any of those 10 patients. They stay in the hospital 1 or 2 days, and I've had no major complications in those revisions. That's quite in contrast with some of the reports of these revisions. And it may simply be that now with measuring metal ions and being aware of this problem, we're picking these people up earlier. If you let them go on and on and on, those may be more difficult revisions. But if you catch them fairly early, my experience has not been that they're any more complicated to revise than other implant failures.
One question for you.
Yeah.
The patients or potential patients always ask me, I have AVN, so I can't have resurfacing, or am I at the right stage to have resurfacing? Could you address AVN? And
yeah, I can address AVN. That's one of those areas where that's a little bit higher risk. The papers show that, studies show that there's a little higher risk of failure with AVN on the femoral side, because you have on the femoral side then with resurfacing osteoarthritis. I've had that experience in the past, but it's not much higher. It's a percentage point or 2 higher femoral failure rate. There's, of course, no different in the failure rate on the socket because it's the same. The problem in AVN is you've lost bone. You have more dead bone in the femur. So in some ways, it's very much the same as having a cyst from osteoarthritis. If you have a bigger cyst, you have more bone loss. If you have less bone to work with on the femur, you have less to hang your implant on. At some point, there's too much bone loss and you have to cut it off and anchor your implant in the femur, a regular stem total hip. In general, I have not found much difference in the failure rate in my own experience with necrosis if less than 1/3 of the femoral head is dead. We scrape it out, we bone graft it. And now, especially with the uncemented component, I'm not sure I've had any failures in my osteonecrosis on the femoral side with the uncemented component. I haven't carefully looked at that, but my sense is that it's no different. We just scrape out the dead bone, fill it with bone graft. There's good live bone around the base of the femur. We put the bone ingrowth implant in it, and that live bone around the base grows in and attaches. So that's something I clearly need to do, carefully subgroup out that group and see if there is any difference in the femoral failure rate, in the femoral neck fractures or the femoral collapse. But in my first 1,500 resurfacing, this data is on my website. All my complications are listed there. I've had 6 femoral neck fractures, and I've had 2 femoral head collapses. And so, I mean, the odds of that in 1,500, it's less than 1% femoral failures in the first 2 years of uncemented resurfacing. In the first 4 years of uncemented hip resurfacing. So, yeah. And with those low complication rates, I don't think I could find a difference between necrosis and osteoarthritis. And I really do not stratify. I do resurfacing on patients with necrosis. It's probably about 10–15% of my patients.
Okay. Well, the good news is, in the hands of a good experienced surgeon with a good device, hip resurfacing is as good as it always was, and will hopefully be around for many more years.
Well, I think that's true, and I think our results, the point is our results are actually getting better with resurfacing as we solve these problems. I'll give you several examples. We are going through systematically and trying to solve the problems. And that's what you do when you have a new procedure. You come up against problems that you didn't expect, and you don't abandon it. You keep working to solve those problems so that our survivorship now at 2 years is 98%. We have 1.5% failures at 2 years. You know, in the latest ones we've done. I mean, we've gotten better and better with them. So I think there's a lot of hope.
Good. Well, thank you.
Great service.